Good afternoon, everyone, and thank you to the moderators and for SAGES for the opportunity to present. I have nothing to disclose. So talking about performance, us all being surgeons, we would like to presume that we're going to fall directly into the green zone, preferably off the darker green zone, perhaps even beyond excellent. And in the context of this, and when bringing a new innovation and surgery into your own practice, how do we know that that's how we're going to perform? And how do we know for our patients that's how we're going to perform? And how are we going to be measured? Well, there are various outcomes that people look at. And having recently become an attending, I now know that there are various things that hospitals are very interested in. How long do your patients stay? How much do your operations cost? How long is the wait for your patient to see you? And so on. For patients, these measurements and outcomes can also be recorded, and they talk about satisfaction. Satisfaction surveys come up a lot, but also, from our point of view, for a patient, we want to know what is their morbidity and mortality. What are the outcomes, and how have they changed by bringing in a new practice into your operative cohort? Are you having more leak rates, for example? Are your meshes failing? How do we collect this data, and how is it important? From a surgeon point of view, if you're looking at the case itself, what are the things that I want to know about my outcome? How successful was I at this operation? How many steps of the proposed surgery did I do? Where did I get stuck? At what particular point did I get stuck? Was it absolutely brilliant? And how do I measure these things? And actually, how a case goes and the outcome of that case then has implications on those hospital outcomes. So if the operation was straightforward, the time tends to be less, the time in the operating room is less, the overall cost is less. If you didn't drop the mesh, you therefore didn't use 2 meshes, and so therefore keep the cost of the operation down. And if the operation went well, that tends to also impact on your patient. So focusing on the surgeon, what is a learning curve? We heard earlier on today about one definition of that, but just looking in the dictionary, this can be defined as the rate of a person's progress in gaining experience or new skills, but alternatively, the course of progress made in learning something. So I'd be remiss to mention that actually my prior research group would define this as actually the proficiency gain curve, because the difference that they argue, and I would be inclined to agree, with the surgery, you don't want to just learn the surgery, you don't want to learn the steps. You actually want to become proficient at it. And so that's really what that describes. Can I do this surgery, but can I do it well? So there are a few things that you can do to impact that curve. We've mentioned a little bit about some of these already, so I'll gloss over a few. But the 4 main things that I see how they can be categorized is going on a course, patient selection, mentor, and assessment and feedback. So the courses we've talked about a little bit already this afternoon, but they have varied ways that you can be taught. Virtual reality, box trainers, cadaveric models, and also porcine models. It really doesn't matter what you do as long as you go on a course of some degree. Research has shown that actually the best model is cadaveric model, but now I've seen the 3D models, I kind of feel that maybe we should be going on those. However, the cadaveric model is perceived to be the most effective because obviously it's the same anatomy, the same setup, and the reason why the course is good is that it gets you started on your proficiency gain curve without putting a patient at risk. You get familiar with the instruments, you can fire staplers on bits of sponge before you use it on the tissue and so on. And you also have the opportunity to discuss the case with many experts who are there at those courses and pick up their tips and tricks. What things do they run into? Not just for the actual operation itself, but also the other steps that we've talked about already this afternoon. How did they get around the legal implications of having X, Y, or Z? Then the next thing is to get your mentor. So a wise surgeon once said to me that the only thing that 2 surgeons could agree on was how awful the 3rd surgeon was. So choose your mentor carefully. This mentor should be someone that you trust, someone who trusts you, someone who can communicate well with you, and someone who is going to be honest and keep you straight. And give you good feedback and evaluation. The mentor doesn't necessarily have to be there in person for every single case that you have, and there's now good research that demonstrates that telementoring is a very good way to then continue that level of mentorship and support, but at a distance, and especially if that includes some telestration. The mentor can also guide you about your case selection, and people obviously all come in different shapes and sizes, and that can make a big impact depending on what kind of surgery that you're planning to do. So, for example, if you're doing colorectal surgery, you wouldn't want necessarily to choose a man with prior perforated diverticulitis for your first colon resection, given that this can be particularly challenging. And the disease process also goes into that. So you need to set yourself up for success and ask your mentor for their experience. And also in the literature, there are now, again, many different papers that describe for whichever kind of surgery that you're planning to do, what is harder and what's easier. So do the easy things first. And then the next thing is to assessment and feedback. And for this, you really need to collect your own data. There are various evaluation forms and different kinds of feedback, which I'll talk over a little bit over each of these examples. And they can look at different parts of your operative performance. So OSATS was developed for open surgery, and this looked at overall proficiency, so how well you handled the tissue, your ease of manipulating the instruments, and so on. Then there's the GOALS, which was developed for laparoscopic surgery for cholecystectomy and also for hernia. And this again looked at proficiency. The Global Assessment Score looks at something slightly different. So how can you perform something independently? So how much is your mentor having to take over or just talk to you? LCAT is a structured analysis which was developed for laparoscopic colorectal surgery. And this can be performed in real time and also just with video analysis also. This is very detailed. And it's something that you can use with blinded assessors. So that is something that we use in the UK to give people, gets people signed off, if you like, or declare them competent in doing laparoscopic colorectal resections. And then a slightly different approach was to look at the feedback that are given at the end of a surgery. And for those who teach medical students, you may be familiar with the rhyme, so reporter, interpreter, always forget M, and then educator. The same can be applied for surgery, and through this study, they developed these different categories. So first, a technician, so you know the steps and know how to kind of go through things. Next, anatomist, so actually truly understand the anatomy and getting a better idea of how the operation is developing. Anticipator, thinking about the different steps and waiting for knowing what's going to come next. Strategist, having more of a strategic approach. And then executive is that you know when to switch between the different strategies that you have. And this is a good way for your mentor at the end of your surgery to say, okay, this is where you're at now, and give you an idea of like whereabouts you are on your curve. Video analysis is extremely important, and in order to do that, you have to do the next thing. You have to collect your data. So if you have opportunity for video capture, then just take it, because this enables you and your mentor to go through the video and give more meaningful feedback. So instead of just saying, oh, I don't think you used your non-dominant hand well enough in this point, or did you see the way the mesh didn't unfold right? You actually can then go back and look at that, and that is much more solid for learning. And then with that data, capture the other things that people want to know about, the case details, complication rate, the length of stay, and also operative time. And then that would just give you the best data bank that you can have in order to find out and plot where exactly you are on your curve. So in summary, we talked a little bit about performance, what learning curve means, the importance of a mentor, case selection, evaluation and feedback, and why it's important to capture data in order to plot your outcomes. The main take-home messages is that choose your mentor and choose your mentor wisely, and don't just have a mentor is the main thing, and collect your data and evaluate it, so that then you can be the top arrow and not the bottom cross. and then you will go to green. Thanks.
Thank you.